afternoon. We meet up again. My name is Dr. Wong Teck Lee. I'm a consultant cardiologist. Today, I have an old friend. His name is Professor Dr. Vicknes UMMC. He is not young, and he's a founder and head of a division of neurosurgery of University Malaysia. And currently, he's a head of the business unit of Faculty of Medicine. And he's also the founder and director of the Center for Biomedical and Technology Integration. So he's a very experienced surgeon in all the things that related to head injury and the brain problem. So with that introduction, I pass the floor to Professor Vicknes to talk about everything that we need to know for head injury. Dr. Vicknes.
Good afternoon, everyone. Good afternoon, Dr. Wong. Thank you for Dr. T for inviting me to give this interesting topic. Yeah. So let me just share some slides first. Yeah. Can you all see the slides?
Yes, we can see the slide. Okay.
So the topic I've been tasked today to speak about is head injury, the risk stratification, the pros and cons of neurosurgery, right? So I had a bit of difficulty trying to understand what exactly was required, but Dr. Wong was kind enough to give me some heads up on the kind of audience that I have, and I understand that majority of you will probably be general practitioners, and you get asked difficult questions by family members and patients. And just before you came on board, there was this question, there was this comment that I made, is that, okay, so I'm not a GP, so I'm not sure at what kind of questions patients will actually ask you in your practice when they want some queries, which I'm hope that then you can ask you can type in your question and I can try and answer those questions. But I'm going to base a lot of this talk on, because I also function like a general practitioner from time to time, because patients bring in their relatives' scans and their relatives' questions to me to ask me my opinion on what I think should be done, or is it being done correctly in this other hospital, etc., etc. Would I do something very different? Can they bring the patient over? So that's the kind of things that I get asked. And based on, and sometimes also there are difficult problems in which a patient may be brain dead, for example, in another hospital, and the family is not quite willing to accept it. And so they want a second opinion from someone to confirm whether this might be the case, right? So as a practitioner, I figured that you may want to know a little bit about also the patient management. So I'm hoping to cover a little bit about the immediate post-trauma care in case the patient is brought to you to your clinic. Then in acute care here, I mean like when the patient is brought to, he's under my care in another hospital, and then the patient comes in to you, sorry, not the patient, but the family comes in to you to ask some explanation of what we may be doing in the hospital for their loved ones. Okay, so that's what I mean by acute care. And then long-term care is when we actually send them back into the community. A lot of times they still need a lot of care in the community, and that's where general practitioners and all come in and play a very, very important role in the long-term care of these patients when they are once they are back to the community, and a miscellaneous other topics that we can cover. So it's a small overview of relevant management, and also primarily what do you tell patients and their family. Okay. So in immediate care, this is a phrase that we use, or been used since I was a trainee: time our neurons. So the more time that is wasted to get a patient to a proper facility to prevent certain things from occurring, they are going to lose more neurons. Okay. So we have this concept of primary brain injury versus secondary brain injury. So primary brain injury is what actually happens as a consequence of an accident. Okay. So usually there's very little we can do for primary brain injury. What has already happened has already happened. But a whole cascade of events will take place which can cause secondary brain injury. So the part of the brain that is impacted by the trauma, we call this a primary or the umbra. And then there's a surrounding brain tissue around it, which is the penumbra, like what you see in a, what do you call that? I forget what you call that. So there's an area around it that will progressively die off if we don't look after it, okay? And the whole basis of modern neurosurgery today is the prevention of secondary brain injury. Okay, umbra and penumbra. So what you see in an eclipse of the sun and the moon, okay? So there's the umbra where the center bit's all completely dark and the penumbra that's outside. So our whole role is to prevent the penumbra from dying off and also expanding out further. Now, two very important things that everybody can do to prevent further damage is to make sure we prevent hypoxia following head injury and hypovolemia. If you have hypoxia post-trauma, and this could be due to the chest injury or aspiration, the possibility of the patient dying from the head injury is about 40%. If you have hypovolemia, for example, the patient may just have a simple laceration wound that is bleeding profusely, or a displaced long bone fracture and is bleeding internally, or an intra-abdominal injury, the risk of mortality is again 40%. But if you combine both of it, if the patient has got both these entities, the patient is almost 100% likely not to survive, okay? So the most important thing here is the usual A, B, C, D, E of resuscitation. So please make sure if someone scoops the patient from the roadside, brings them to you, or if you happen to be dragged out of your clinic, I've heard a number of GPs get dragged out of the clinic because an accident has happened just on the street in front of them. So first, most important thing is make sure the airway is clear. There's nothing stuck at the back of the throat. The patient is breathing adequately. Circulation is fine. Then do a quick assessment of the dysfunctional neurology, and then expose the patient to look for other injuries. Always keeping in mind that you're protecting the C-spine. Now, if you happen to be in the unfortunate situation where you are driving a car, this has happened to me a few times, not once, and there's a crash in front of you, right? So you have to be very careful when you extricate somebody out of a car. You have to make sure, first of all, that accident itself is not going to endanger you when you go in and try and rescue. So make sure the surrounding area is clear before you try and go and rescue the person. And when you extricate this person, you have to make sure the patient's C-spine is intact. About 15 years ago, I was coming down the Mont Kiara Expressway when a car, they were two cars with the early 20-year-olds were racing each other, and one car hit the side of the curb right in front of the Selangor Club, and then cut across my vehicle and then flipped upside down, okay? And then the car was smoking as well at the same time. The driver and the passenger, the backseat passenger and the assistant able to crawl out. The driver was stuck in his seatbelt hanging from the roof. So my wife and I had to very carefully, we had to approach this car. We had to peel the car piece by piece, the door, and slowly try and lower the patient down because the car was also smoking and we didn't want the whole thing to go up and move him to the side of the road. So these things happen, and in Malaysia, it's not uncommon, okay? So I myself have been involved in something like this at least 3 times in my life. Okay, that's more than average, I think. So you have to make sure, and people bring patients to you in a GP clinic. You may not have all the things there necessary, but you should be able to do the A, B, C, D, E, make sure these things are done before the patient is sent off. And then you have to make sure there's no intra-abdominal injury, thoracic injury, and long bone fracture. The last thing is dealing with large scalp lacerations. So scalp lacerations can actually bleed quite profusely, right? And this should be stitched in a single layer nylon or whatever big suture that you have, like stitching a sack and then putting some dressing and sending the patient off. Because patients I have seen almost patients come in hypovolemic shocks from simple assault to the scalp with a parang, and they bleed profusely. Now, minor head injuries. Now, this is something that you are most likely to see. So this is patients who come into the Glasgow Coma Scale of 13 to 15. Now, I'm only going to focus on 15 because I'm sure most of you, in fact, all of you probably, the moment the patient's GCS is between 13 and 14, if the patient is a little bit drowsy, you'd be very sensible and send the patient off after, of course, doing the A, B, C, D, E, and the cervical spine. But it's very important to focus on the 15 because the 15 can be looking very well to you and maybe harboring a serious problem. Or sometimes we misjudge a 15. You see, to be a proper 15, the patient must be able to open his eyes spontaneously. The patient must be able to obey commands easily. And the patient must be able to answer in full sentences. Sometimes the patient may open his eyes and look at you for a while and then slowly close his eyes. That's actually not technically a 15. Or if you ask a question and they may give you just a single word answer, that also may not come up to a 15, okay? So when you see things like this, you have to be very, very careful, okay? The most important thing, I think, is the mechanism of injury. Often when I used to teach general surgeons in the past, I always used to tell them, the Indonesians are hardy people. An Indonesian will fall off a construction site of 5 stories, come in, dust himself, and walk into the clinic. Okay. Most majority Malaysians, we will trip over our leg and we will land, and then we will almost die always. Okay. So, but you have to be aware of the mechanism of injury. If someone falls off a big height, someone has been hit by a heavy blunt object, or has there been a penetrating injury to the skull? These are important things. The next thing to look for are lucid intervals. The classic description is someone who's playing football and is head-butted or hits the goalpost or comes down heavily, is unconscious for a short while, and then the patient comes to the clinic or whatever, and then they are seen, and then they are sent home because they are conscious and alert. And what happens is they are found dead next morning in bed because they have an extradural hematoma that has gradually expanded, okay? There was a famous actress, her name escapes me. She was out in Canada skiing, and she bumped her head. And when the ambulance got there, mind you, this is in Canada. So the ambulance got there, she was looking fine. Everybody said she was fine. She was sent home, and then she died later that day. She was found dead because she had an extradural hematoma, right? So one has to be careful. I myself, when I was training in the UK, we had a very young girl who was brought in the morning. She had fallen off a horse, as you commonly see in the UK, and bumped her head. Now, when she came to see us, she was actually very well. And after a little while, short period of observation, she was sent back with head injury advice. She was brought in by ambulance dead about 8 hours later because she went back home, she got herself into a bath, locked the door, and then she had a seizure. And she had a small hematoma. Okay. So when you come off a horse, if you fall off a big height, there's a possibility, even though you are well, you may have a small hemorrhage. So it's better to be very careful. Also be careful with old people, right? And they can have problems and they may be difficult to manage. Patients with comorbids like diabetes and hypertension. Now, a very important thing is under the influence of substances. Alcohol is a common problem. So sometimes patients come in smelling of alcohol. Patient may be marginally dopey, had an injury, and then the patient is just brushed off and said under the influence of alcohol and sent home. And then what happens is the patient turns out poorly because actually the alcohol is just a little bit, and the patient actually had a significant head injury. Now, this doesn't happen only in the community. Yeah? In my early days in the university hospital, a major general hospital general hospital did not refer the patient to us. 2 days later, some family members came looking for me and this happened, there were 2 cases in a month apart. And they came looking for me because they said their relatives have been admitted in this particular GH and he has been unconscious for 2 days. 2 days, not 1 day, not half a day, 2 days. So I called up I got my medical officer to call up the medical officer the other side and say, oh, this guy is was under the influence of alcohol, so we're just observing him. Now, unless you are infusing alcohol intravenous onto the patient, he is not going to be unconscious after 2 days, after 6 hours. That is why when they come to hospital, we put them on quarter-hourly Glasgow Coma Scale monitoring. So the GCS falls as the patient passes along, that something is happening, or GCS does not improve. But if the GCS gets better, then we know, it's just concussion and the patient is coming up. So the GCS is very, very important here. Now, the next thing that you look for is when a patient has got an acute care. Okay, here, these patients, you are probably not going to be managing. But as Dr. Wong pointed out to me, patients' relatives, family, and friends may come by to see you, and they may want your advice or may want your opinion because a relative of theirs has been involved in a road traffic accident and is being managed in university hospital, for example. And should they take the patient to another private hospital? Okay, that's a common question. Is this the correct thing that's being done? Or this doctor says to me that this patient is not doing well. Is it correct? Okay, so they may ask you these questions. Okay, some of them are difficult questions to answer, and I'll come to that in the end. Okay, so some of the things that you have to ask is, what is the conscious level of the patient when the patient gone in? Okay, what's the GCS? Obviously, patients' relatives will not be able to tell you what the GCS was, but usually patients with the GCS of 8 and below are doing poorly because that's a severe head injury. Okay. 8 to 12 don't do great as well. They are moderate head injuries. But, you need to know what the GCS was. If the patient is able to tell you what the scan shows, and I will discuss some of them with you afterwards, you will have a better idea of whether the head injury is severe or not. Or if there's a medical report that says to you, okay, this is what the patient sustained, then maybe it's not so bad, right? Because reading an CT scan is a specialist skill, right? And it would be very unfair for the patient to ask you some of the more difficult questions. But when you read the report together with the GCS, it makes sense. Older patients, if they have a head injury with a hemorrhage in the head, they are going to do poorly. There's a paper that came out years ago, and if you are 35 years old and you have an intracerebral hemorrhage, the outcome is going to be quite bad, right? Types of intracranial injury. So I will go through that again later. And are there other coexisting injuries? So patients who sustained a head injury with a bilateral pneumothorax or intra-abdominal requiring laparotomies or multiple long bone fractures, the prognosis may be poor. Now, location and right versus left hemisphere is very, very important. Okay, the left hemisphere in majority of patients, including majority of right-handed patients, is the dominant hemisphere. The problem with hemorrhaging in the left-hand side is that it's not just that the hemorrhage will cause problems, but the patient's ability to recover because he or she has difficulty understanding instructions, difficulty following physiotherapy and rehabilitation makes it very, very challenging to get them back. So like for like, a right-sided head injury patient will usually do better than a left-sided head injury patient, okay? I know this says head injury, but I've included cervical spine because if patients come in the cervical spine, obviously depends on how high up the cervical spine is being transected or contused or compressed. The higher the cervical spine injury, the worse the prognosis. So patients with C7 or T1 injuries, they may be paraplegic, but they are usually able to use most of their upper limbs except for their fingers, right? So they are usually going to do okay. Patients with C3 fracture, C2 fractures will have respiratory issues and problems like that. C4, C5, C6, they're going to end up pretty sawn out because they end up losing all 4 limbs, and recovery is very, very difficult, okay? Also find out from the family what the ICU care is like, how many days the patient has been in ICU. The longer you are in ICU, the worse the prognosis, okay? And then if you start to develop nosocomial infection, which is almost a must after you've been in ICU for 3 to 5 days, then things go south from there, and the prognosis is also very poor, okay? So there was a paper or joke, I'm not sure. So it said that the more lines you have in a patient, the worse your prognosis is going to be. Okay. So if you have an arterial line, a central line, 2 or 3 peripheral lines with an NG tube, you're obviously going to do quite poorly. Okay. So the more lines you have, I also extrapolate that. I say the more anesthetics you have around your table, the more likely you're going to do poorly. Okay. Okay. So the role of neurosurgery. Okay. Now everybody thinks as a neurosurgeon, my job is to manage trauma. Actually, neurosurgeons to manage trauma, actually, that's only a very, very small portion of our real job. Okay. And management of head injury, I mean, we oversee the management of head injury, but it's only a small portion of our real job. Our real job is taking out tumors, doing aneurysms and stuff like that. Okay. But to be able to run a good neurosurgical unit, you must have a good neurotrauma ability. Okay. And it's beyond surgery. The management of a head injury patient is beyond opening their skull, is way beyond that. Okay, because there's a lot of management, a lot of physiology involved in making sure that the brain is being looked after properly during this time. Because the patients go through a stress response and all kinds of things at the time. Okay. Today, for the last 23 years in University Hospital, anybody who's had a head injury of GCS 8 and below, first of all, they'll have an ICP catheter inserted. Okay. That's a little piece of wire that goes into your head, and we monitor the brain pressure. Okay. And based on the ICP, we decide whether to take out certain hematomas or do decompressions. Now, I'm going to skip the next 4 points, and I'm going to cover them as part of a few other slides. Okay. So this is a scan of a 10-year-old girl. This was years ago that I did. She came in with a GCS of 5. 1 pupil not reactive. But she had a skull fracture with an extradural. So you can see, I'm not sure you can see, but can you all see my arrow? Do you all see the arrow on the screen? No.
No, cannot see. Oh, yeah, can.
Okay.
Can see.
So this is what you mean by a biconvex, okay? This is what you mean by the biconvex. So one part of the convexity is the skull, and the other part of the convexity is the clot itself. So there's a big hematoma, nice biconvex, and it's compressed the ipsilateral ventricle. A GCS of 5/15, a pupil's 3, 5-. We rushed her to theater. We took out the hematoma. The patient did very, very well. She went back to school, right? But this is an extradural hematoma. An extradural hematoma, the forces involved, if it's just a pure extradural hematoma, isolated, the forces involved are not very large. The prognosis, there's no primary or minimal primary brain injury. The patients usually do very well if you get them out early, right? When I was in UK, again, it was a winter day, and the university students there get very naughty. They got drunk because it was the opening night of the university's orchestra, and they decided to throw one of the students into the waterfall, right? The student was left in the fountain, and was found 2 or 3 hours later, brought to hospital. He had a large extradural hematoma, which I took out. Okay. About 2 months later, I read that he was back in the orchestra playing the music instrument. He was very lucky on 2 accounts. It is a low velocity injury. Whoever found him early enough, and he was kept hypothermic due to the bad weather and the ice water. Okay. But he did very well. So extradural hematomas by themselves do very, very well. The same thing with depressed skull fracture. So someone hits you in your head with a hammer, there's usually going to be not that much velocity. You may have a very dramatic skull fracture. You can develop seizures. You can develop hemiplegias if your skull fracture is right over your motor strip. But generally, you will do well because the general brain has not been damaged. Okay? The velocities are small. On the other hand, if you have a subdural hematoma, an acute subdural hematoma, okay, this is an acute subdural hematoma. You can see now it's curved on both sides. Okay. Acute subdural hematomas do poorly, especially when it's an acute subdural hematoma in a young patient, right? Number one, the brain is full. These are usually high velocity injuries, like our motorcyclists, So you get the impact is on the right side of the head. The forces are transmitted across to the left side, and the patient then bleeds on the left side because the brain swings and it hits the other side. They have a lot of rotation injury, and they also have a lot of rotation and torsion injury. Okay, so they tear a lot of neurons in the brainstem, and this is what causes a low GCS. Okay, so there is this concept of coup versus contra coup. Some of you will remember from medical school. Coup is the injury that occurs directly below the trauma. Contra coup occurs on the other side. So if you have contra coup injury, that means the forces have been quite large. The prognosis is usually very poor. So when you see a young patient or you hear of a young patient who has had a subdural hematoma after he or she has come off a bike, we have operated on the patient, etc., the patient is usually going to do poor. Okay, they're usually going to do poorly, right? Now, if you hear the patient has got a decompressive craniectomy, now this is a life-saving procedure, right? All of you know the skull is a closed box. Inside it sits the brain, CSF, and blood flow. Anything else coming into it, like a blood clot, brain swelling, hydrocephalus, will put up the pressure because the skull cannot expand, unlike the abdomen. So what happens is nowadays we do a decompressive craniectomy. The ICP is very high. We cannot lower the ICP with medication. What we do is we take large chunks of the skull out. Okay, we remove the frontal part, bifrontal craniectomy, or we remove the side of the head out. Okay, to allow space for the brain to swell out. Okay, until the skin restricts it. When we reach a point that we have done a decompressive craniectomy, that usually means the prognosis is very poor. We are doing this procedure to save the patient's life, right? So we may save the patient's life, but the patient himself or herself may not turn out very well. Okay, so you will see sometimes patients coming to your clinic where their skull is missing. That means they've undergone a decompressive craniectomy. At a later point, maybe a few months later, we will go back and put either the patient's own skull back if it's thawed in the fridge, or we'll put a titanium plate or an acrylic plate or one of those things. So decompressive craniectomy is a kind of do or die procedure. Now, a neurosurgeon's biggest fear is to convert a patient who is going to die to someone who is in a vegetative state. That is our biggest fear. Fortunately, these decompressive craniectomies do not seem to do that. They have they have poor outcomes, but they are usually not in a most of them are not in we don't leave them in a vegetative state. Okay. Now, this is another variety. Okay, this is a chronic subdural hematoma. Now, this you are likely to see amongst your patients, especially the elderly. Okay. Now, if you look at the brain here, if you look very closely, if you look at the other side, you can see the sulci running right up to the bone. On this side, you don't see any sulci. The sulci is actually compressed, and there's a black line here, and beyond which there's this collection of blood, which is now about 2 weeks since the trauma, which is isodense with the brain. Okay, this is a chronic subdural hematoma. This patient has had a previous stroke as well, but this is a chronic subdural hematoma. And chronic subdural hematomas is a very gratifying operation to treat. Okay, how do you recognize this patient? History is very important. History is usually short. The family may notice that over a 1 week period or 2 weeks period, the patient's neurology has progressively deteriorated. Okay, this can be in the way of their mental functioning, or they found to become weaker, or they generally become slowing. We have had patients being referred to us from the psychiatric department when their family has brought in patient masuk hantu, or patient, something is wrong, psychiatric. Fortunately, someone realized that it's very short. They've done a scan. Patients have come in with a stroke. It's very, very common for these patients to be labeled a stroke. 20 years ago, when these patients came in, a lot of them were labeled a stroke. Today, because CT scans are easily available, someone would have worked out the diagnosis of chronic subdural before they come to see us. Some of the times, not always, you may have a history of a minor head trauma, and this can be very minor. someone who went under the storeroom, under the stairs and knocked his head. Okay, someone who accidentally bumped the side of a door. Okay, something very, very, very simple. But even they say, even if you knock off your head, you can develop a chronic subdural. Now, this is because the brain is floating in water and you got your veins that are crossing to the skull. And as you get older, as your brain shrinks, there's more space for the brain to move. And so there's a higher likelihood of one of these veins to rupture. Now, these patients quite often are also on antiplatelets and stuff like that, okay, which compound the problem. However, all we need to do is drill a couple of holes in their heads, let the spirit out, and the patient is fine, okay? This is a kind of guy who will be dopey at this moment. We will do a chronic subdural. Next morning, you will see him reading the newspaper. The recovery can be that miraculous and that fast, and the prognosis is good. So if you have patients and relatives who have been diagnosed with a chronic subdural, in Malaysia, it's very easy to label someone, oh, sudah tua, tak payah buat apa-apa, okay? We have done chronic subdurals on patients who are 90 over years old and they do well, okay? So it's worthwhile to pursue this. This is about the only operation I would recommend done on myself if I ever have a problem, okay? Right? This is another chronic subdural, I think. So you can see the brain has got a lot of atrophy. Okay, so there's a lot of space. And you can see the subdural here. Oh, that's the same. No, it's a different patient. You can see a thin subdural here. Okay, so usually progressive worsening neurology. But there's a 10% chance after we have drained the subdural, it can recur. Okay, so we usually observe if the neurology comes back again, then we would repeat the scan. I, for one, do not repeat scans. If a chronic subdural is improving, I just leave it alone. The reason for not repeating a scan is because when you're old, you're already atrophic, and your brain will never expand to fill up the entire space. So we did a scan. If the patient is very well and you find a small collection, everybody's going to get very excited, stressed, okay? So unless the patient's neurology deteriorates, again, I usually don't do a scan. Okay, this is the outcome score. So these are patients now who are going to come back to you, okay? So this is the standard outcome score. 1 is death. 2 is neurovegetative state. Patients unresponsive. Okay, this is number 2 is the worst state to be ever in life, okay? And then comes number 3, which is severe disability, where you need dependent on daily support. Moderate disability, they are independent for most things they can do. And good recovery, resumption of normal life with minor neurological and psychological deficits. Now, it's very, very interesting. In about 2006 or something, one of my medical officers did a study. We saw these patients, we were doing decompressive craniectomies, and they had all done very well, okay? Or we thought they had done very well. They came to our clinic, they were boleh makan, boleh minum, walking around, doing everything. So we thought they were all doing very well. Good outcome was very high. Then we did a functional assessment on them, okay? Like a Bartels index. We did a functional index. Half of them were screwed. They were not doing very well. When we did a neuropsychological assessment on these patients, all of them had problems. Okay? So more and more, we have to understand that the psychological impact of head injury is quite significant. And even in patients with minor head injury can have significant psychological problems, right? And the psychological problems are due to either the injury themselves, when you have small petechial hemorrhages, or sometimes the trauma on you. Now, we all have, most patients have loss of consciousness, or they cannot remember the accident. It's not shown anywhere, but I personally feel that this loss of consciousness or this forgetting the accident is actually a body's mechanism to defend your mind and your brain, to protect you. Okay? If you can't remember what happened to you, you're usually better off. Okay? And I think it's a protective mechanism, because I find generally when I do a lot of assessments for head injury for medical legal purposes, I find the patients who can remember the accident seem to have more psychological problem than somebody who got hit at the back of the head, right? For some reason, they seem to get on with life better if they got hit at the back of the head than when they got hit at the front of the head, or when they remember what actually happened, okay? Many, many years ago, I had a little girl who was riding a bicycle and got hit by a car. And she didn't lose consciousness. She got stuck under the bottom of the car and got then dragged for about 20 meters or so, throughout being conscious. Now, you can only imagine how psychologically impacted this little girl was. Okay, I cannot even think about how she must be coping. Yeah. So maximal rehabilitation recovery takes 6 to 12 months. So these are patients who are going to come back to the community. They are going to see you. Maximal recovery will occur within 6 or 12 months. Now, a lot of patients keep saying, a lot of families say, oh, tunggu lagi, just wait, he must get a bit better before I can do exercises. No, all the exercises must start immediately. And they've got the clock is ticking, because they make the initial recovery is slow, then it accelerates, and then it flattens out. So you want to maximize the recovery, right? In that period of time with 6 to 12 months. Of course, there's some recovery that continues to occur, but this is the window that they must, and it's the job of all doctors looking after them, make sure they get physiotherapy, occupational therapy, speech therapy, social support, psychological care, right? It all must intervene at this phase in time. Okay, it's no point waiting 1 year later or 6 months after it's a little bit better. No, it has to start sooner. Finally, this is what patients will come to see you when they are in the community. They may have a tracheostomy that may need to be looked after, right? A lot of patients will be discharged with either a Chiles tube, which, you must be aware of crusting and cleaning and washing. Patients have NG tubes. Ever so often they will pull it out, and a local doctor will be called in to stick it back in. They have PEG feeding tubes, gastrostomy tubes. Sometimes the patients are very restless and they will pull it out. And that has to be done in a specialized unit to reinsert. So you need to press it and send it back. Skin care from bed sores and all that. These patients will have other general medical problems like diabetes, high blood pressure, and all that needs to be controlled. And as his patients comments on their physiotherapy and all that, they have also got a tendency to fall, right? And you will assess the patient who has fallen. This is like low impact injury, but you will assess the patient who has fallen again by GCS, other injuries, impact, etc. Okay, and then decide. It is, you see, overseas, quite often when we have done decompressive craniectomies, patients are very rajin and they'll wear a helmet. In Malaysia, they don't wear a helmet when they have got no skull to protect them. So if they get hit in their place where there's no skull, they are in serious trouble, okay? You may see patients with post-traumatic seizure. Other than the usual management of putting them on their side, making sure the tongue doesn't fall back, etc., sometimes you may need to give them some Valium to stop the seizure before they're transported to the hospital. But please make sure with that his airway is protected, yeah? And some patients may develop hydrocephalus. Now, if you see a patient who's had a decompressive craniectomy, that means we have removed the skull. So if you see the patient immediately after we remove the skull, the brain will be bulging out. After about a week or so, as the swelling settles down, the brain will slowly settle back inwards. Sometimes the patient brain will even sink inside if you have removed some clot and all that. But from time to time, you'll see patients who are then gradually developing the brain swelling out again. And these patients possibly have hydrocephalus if they do come by and see you. And with that, I think that covers the range, the kind of problems you'll have. Oh, there's one other thing that I forgot to mention. Now, patients will often come and see you because they have been told in a private hospital the patient is brain dead. They are not going to survive. So you may be the doctor to which they will bring the scans and pictures to show. More often than not, they come to see me, right? So it's very important to explain to them, to go step by step. We have to be very, very careful because sometimes some colleagues like to be very clever and say, I would have done this, I would have done that, maybe they should have done it. This is not the time to score points, right? It's not the time. I think we just basically need to sit down and explain to them, look, First of all, find out how bad the injuries were. Look at the scans, how bad the scans look like. And in the other side, does think that this is clinically brain dead, then and if in your mind you think that this is really poor, then I think it's good to be supportive. So the story is in sync, right? Because patients will always, because you remember the vast majority of people who are involved in road traffic accidents who are very poorly are young adult male. Most of them would have been just going out to work in the morning. That evening, some policeman will knock on the door and tell them that they are in hospital very unwell. 3 days later, someone's going to tell them they're clinically brain dead. So it's very difficult for the family to cope with this. And it doesn't help when people try to be clever, right? So if you think that everything has been done, really everything has been done, or the patient started off very, very poorly, right? And would have done poorly even under your care, it's good to say, look, I think the prognosis is poor, right? And don't confuse the family any further, right? So I think you all will see this from time to time. And with that, I thank you. Now, next year, there's this Healthy Aging Conference that's at St. Giles Hospital, St. Giles Hotel in Penang. And there are a lot of interesting topics I'm being told. So hope to see you there. Thank you very much for your kind attention. I see one question in the chat. Is that the one I'm supposed to click?
Yes, thank you, Prof Vicky. I read out the question from you. This is a question from Dr. Manjit. How to diagnose subdural hematoma in a clinic setting? So you talk about acute subdural hematoma and also chronic.
Okay, so an acute subdural hematoma, it's a patient had a major accident, okay, and you won't be able to diagnose it. You just diagnose the patient as having severe head injury and bunkus him to the hospital. A chronic subdural hematoma, as I've mentioned in my slide, will come to see you because the family feels that, okay, first of all, it'll be an elderly gentleman or lady. There's been a recent onset of abnormal behavior, maybe the last 1 week, last 2 weeks, last 3 weeks, or suddenly, progressively, they have been developing hemiparesis or difficulty in walking, or generally just being slow. Okay, just being slow. And then you will always ask if there is the pre-existing, was there any trauma or not, right? The actual diagnosis is only made by a scan, so the patient will have to bunkus for a scan, right? I hope that answers your question.
Okay, there's another question from Dr. Baldev. So in the general practice setting, if there's an emergency of raised intracranial pressure after trauma or motor vehicle accident, what can the GP do to relieve the raised
Okay,
pressure?
the short answer is nothing. Just make sure the A, B, C, D, E is done, cervical spine is protected, put up an IV drip or something like that, and then get the patient on an ambulance and sent off, right? The ICP is elevated when the patient's, when a patient's conscious level is low, it's one of two things, okay? Either there is a big hemorrhage or a big structural injury, like to the brainstem or big part of the brain, or there's generalized brain swelling. And to relieve this, you cannot, even in an emergency department, sometimes we can't do anything. If the patient has got hypoxia, and if you think the patient has got hypoxia and this is causing the patient's conscious level to fall because of hypoxia, and there's a pneumothorax, and if you can put a chest tube, you'll put a chest tube in. Okay, short of that, I think you just bunkus the patient as soon as possible.
Okay, there's a third question from Dr. Kofu. What's the radiology diagnostic test to diagnose brain death for the neurosurgical team?
Okay, radiological diagnostic test is not part of the brainstem criteria. Okay, right. This is how we go about the brainstem criteria. So, first of all, we will look at the whole scenario that led to this condition. There will be things in the scan that will suggest that this patient is going to be brain dead. Okay, for example, severe contusions, brain looks a complete mess. Okay, sometimes you can suggest that the patient is very hypoxic when the brain has a ground glass appearance or sometimes even black. And this happens in patients who, following an accident, have had a massive hypoxic period, or they arrested, for example, they arrested at resus, or they arrested as they were extricating the patient. By the time they brought the patient back around, the whole brain is like black in color. Okay, so that's bad news. Okay, but if the scans seem that this patient is brain dead and the pupils have been fixed and dilated, then we will go on to do a series of brainstem criteria, which is done by 2 senior members of staff. The first one can be someone who has been looking after the patient, but the second one must be usually someone who's completely independent, and they will run through a series of about 6 tests. We look at the pupillary reflex, the caloric reflex, the doll's eye, response to deep pain, hypoxic simulation for breathing. Okay, so we will do these tests, and then if the patient is found that all of them, the patient fails, then we pronounce the patient brain dead, and then someone repeats the test. Sometimes we may do an EEG. Americans tend to do an EEG. Okay, but there's no diagnostic radiology investigation that I would say that's if I see that the patient's brain dead. No. Dr. Nathan, simplify, interesting. Thank you. I was a neurosurgical patient, right? Parietal cavernous hemangioma. Okay.
There's a question for you, Doctor, from Dr. Farahin.
Yeah.
She said that if a patient was diagnosed with extradural hematoma, how is the prognosis of the patient if it was treated conservatively?
Okay, so not all extradurals need to come out. Okay, so it's a judgment call. So if the GCS is 15 on 15, right, and there's just a small hematoma, we will watch. We will watch very closely, and if the patient is stable, that's fine. And then the clot will dissolve like everything else in life, and the patient will be fine. There's no problem. On the other hand, if the hematoma is small and the patient's GCS deteriorates, that's why we do the GCS quarter hourly, then we will repeat the scan, and if the clot's bigger, we go and take it out. If the patient's GCS is below 15, like 14, 13, or anything below that, and the CT scan already shows an extradural and it's moderate size, it'll be a very brave neurosurgeon to say, I won't take that out. Because an extradural is something that you can take out and make a big difference.
Okay. You mentioned about the cases of patient with head injury where they look well. The GCS is 15 to 13. So as a general practitioner, what type of patient that you would send to the hospital to be observed and admitted? Because so some of them will say, I just had an injury and it seems to be okay. And sometimes doctors are not able to judge that they have a serious problem. So
if you look at the slide, I said GCS of 13 to 15, and I qualified that I'm only doing a talk about 15. Okay. So even though it's a mild head injury with GCS of 13 to 15, in most general practice, you do not have the ability to sit and observe them, right? In a hospital, we will put them aside and there'll be a nurse to observe them, do GCS every quarter, hourly, etc., to make sure they improve. Okay. Now, but if you have GCS 15, like you described, the patient is sitting like you in front there and says, I'm fine, I just had a head injury, blah, blah, blah. Okay, what do I do? Okay, now that's a tricky one because sometimes patients are not going to listen to you and they may just look like as well as you. So this is where you start to go back to, okay, what time was the accident? What was the mechanism of injury? What did you bang your head against? Or did you fall down a great length? How old are you? Do you have other medical problems that I need to worry about, And then did you have a lucid interval? Did you lose consciousness? Okay, so these things should ring some warning bells, right? So if the patient bumped his head quite heavily, had a brief period of loss of consciousness, and then regained consciousness, that is a warning bell. Okay. There was somebody who was recently involved. We were not going to discuss this, but there was somebody who was recently involved who fell. He just fell. Okay. Bumped his head against the door, was unconscious, needed some friends to help move him upstairs or whatever. But being another medical personnel, refused any treatment and then did very poorly after that. But the fact that the person had a loss of consciousness, right, for a brief period of time, maybe the patient should have gone to hospital. right?
Okay.
Sometimes even when you go to a hospital, the outcome is going to be the same. But, very hard to say these things. Yeah.
Okay. And during your talk, you mentioned that the only surgery that you would do to yourself is chronic subdural
I
hematoma.
won't do
So
it
what do you
myself. I
mean?
wouldn't mind someone doing it for me. Yeah. Yeah.
Yeah, someone do for you. So that means that all the neurosurgical operation are useless. Is that correct?
No, that's not what I said. That's not what I said. That's not at all what I said. Okay. You see, different people have got different expectations in life, right? Okay. I value my ability to be able to be stupidly funny sometimes. Okay. Or my skill in doing what I do, right? Um, and if I'm going to be left with any kind of deficit, I probably will be the worst kind of patient to my family and to myself, right? So I probably don't want anything done. But there are lots of people. I mean, I live in Section 5 in Petaling Jaya, and it's like I call this area around University Hospital Old Folk Central, right? And every evening you can see people walking who have obviously had strokes and all that, and they're doing well. They're actually doing very well, right? For all means and purposes, with their grandchildren, whatever not. And they go on for many, many years. I just may not be one of them, right? Okay, that's all I mean. Chronic subdural, you can go back to normal. Okay, I can take out a chronic subdural, and tomorrow a real story. My colleague and I one day were at the traffic light outside the university hospital. Okay, and then the traffic light turned red, and then we were there, and then next to us was this taxi. Okay, and then we leaned, and then I looked across and said, "Oh, the fellow looks like he's had surgery." Okay, because he had these two plasters on the side of his head. The taxi driver, okay. Then the taxi driver turns around and I said, "Hey, we operated on him 2 days ago." Okay. So can you imagine? We have just operated on him. He just got discharged. And the fellow is driving a taxi. Obviously, he shouldn't be driving a taxi, but he was driving a taxi. So that's how chronic subdurals go. Yeah.
Mm-hmm. What's the difference between acute subdural hematoma and chronic subdural hematoma? In terms of pathophysiology, why this guy do well and this guy do so badly,
Okay.
even though
So
the same pathology?
a chronic subdural hematoma usually occurs in old people, very rarely in young people. It's a low velocity injury. Okay. It's purely due to some kind of movement that has caused a vein to snap, just a bridging vein to snap. That's all. The brain leaked out a little bit of blood. The blood doesn't get really very absorbed. And over a 2-3 week period, so it happens over a short period of time. There's no brain injury, just a vein has snapped, a bridging vein. So there's a bit of a hematoma, and then it starts to absorb water, and then a membrane forms around it, and then a bit more fluid collects. And so it slowly expands. So it expands over a period of time, allowing enough time for the brain to compensate, number one. Number two, there's no primary brain injury. In acute subdural hematoma, these are all the young fellows who ride motorcycles, usually. So it's a high velocity injury, usually a contra-coup injury. The brain surface gets smashed. The reason there's a subdural there is because the brain is bleeding from the brain surface, it's parenchyma itself. So they do poorly. So that's the big distinction.
Okay. One of the last few questions for you is what's your view about neuroplasticity? I asked you before in another setting, but maybe you can tell our audience here about your view about neuroplasticity.
My view is, okay, people can learn things, and neuroplasticity, what it means is that if something happens to a certain part of the brain, another part of the brain kind of takes over, right? And reorganizes itself, right? The classic teaching is neurons are stable cells. So once you lose your neurons, you can sing to it, dance to it, cry to it, it's not going to come back, okay? In young children, so you would remember in babies, they don't have a right side or left side dominant. So if one side is injured, they actually develop the dominance based on their side, and they actually cope very well. The younger you are, the easier it is to cope, to learn, and to develop, right? The older you are, though there are some exceptions, and Dr. Wong showed us some nice pictures of the gentleman in Singapore, wasn't it? Yeah. But it's more, my take lah, it's more likely that the injuries, number one, even though the accident may have been horrific, the injuries were possibly less severe than what they are, number one. Number two, the person himself was very, very motivated. Okay. is very driven and made sure the use physiotherapy, rehab, speech therapy, and has improved him or herself. And I'm sure maybe the doctors who looked after it made sure the penumbra didn't get bigger, right? And they managed to control how much of brain that was primarily damaged. So that's my kind of take on neuroplasticity. But let's say if the whole brain is smashed, will it recover? I don't think so, I don't think so. Okay. But areas around it can take over. Patient's motivation is a very, very important thing. That's very, very important. Yeah. So that is why in that first 1 year, that window, 6 months to 1 year, everything must be done. The patient must be motivated. Sometimes patients feel like, what's the point? Like I just said to you, right? If I had a chronic subfield, I'll do it. Anything else, I really don't want anything done. See, I'm a bad example. So a lot of patients are not motivated. They are depressed, So there's a big psychological component that kicks in as well.
Okay. If the patient has a significant head injury and they insist to go back, what are the instructions that you can give to the patient and also the family? Because sometimes the patient has loss of insight. They are not aware that they have such a problem. But what are the advice that you can tell the family so that they can watch out?
First of all, you have to make sure if you think that the forces were sufficient, there was I won't call it significant injury. The patient's got a mild head injury, but the history suggests that this may be more serious. Okay. And the patient is insisting on going back. Okay. First of all, you must tell the family, make sure every 15 minutes someone checks up on the patient. Okay. The patient cannot be left alone. The patient cannot consume any alcohol or anything like that. If the patient decides he or she wants to go to the toilet, they can close the door but not lock the door. Okay, and there must be somebody outside who knows what's going on. If the patient's conscious level or anything goes down even slightly from that point, they should be taken to a hospital straight. Don't come back to see me in my clinic. Just go straight to the nearest hospital. Yeah.
Okay. Yeah, I think those are very good explanation from you. And it seems like the head injury awareness are not very high in the public and also with the doctors. So
Really?
are you guys doing something to improve on that?
I always say head injury sadly is a poor man's disease. Okay. I once shocked the Malaysian press, some talk, and I said more people die from head injury than HIV/AIDS. And yet the amount of focus that's given to HIV/AIDS is so much more, right? Because the poor fella who's involved in a road traffic accident is the poor fella who's working. Nobody cares. Really, nobody cares. Okay. And if you were a senior political figure and if you're involved in a head injury, you're no more going to be in a position of power to dictate anything. So you don't matter either, right? So unlike cardiac diseases, right? Okay. So the education, I mean, there's some education, but not too much, right? I mean, I personally feel, and I've commented before, and I've been interviewed before, and I said, the standard of, it all starts with prevention. Okay, and that's where actually I think we are failing miserably, right? Once the fellow has got a head injury, you cannot do anything about it. But it's prevention of head injury that's most important, right? 20 years ago, 30 years ago, I will not see people without, helmets were introduced in Malaysia a long time ago. And the adaptation of helmets was very, very stringent, right? Today, you seem to see more people without helmet. We never used to see more than 2 people on a motorcycle. Today, to see 3, 4 on a motorcycle is the norm, okay? I see children hanging out of the sunroof of a car. Okay. Seat belts have been along for a long time, especially back seat belts were introduced. And I think it was mandated even it's not worn. Right. So a lot of these silly things happen. And traffic rules are not being implemented. They're not being stringently followed. Right. So I think that's where the flaw is. The flaw is actually in the prevention. Because if you prevent the accident, then the head injury numbers will come down. Patching them up, Malaysia is a developing country. We cannot cope with this kind of numbers, right? And as I said, because it's usually the primary brain winner who gets involved in the accident, it already disrupts that person's life. It then disrupts the rest of the people in the family. Usually it'll be one young daughter who will have to give up a job to look after the patient, or, the wife. So immediately they go down into a financial spiral at the same time as well. But this is a prevention problem rather than anything else.
Okay, thank you, Prof. I want to end with a case that I encountered, and I was very upset about it. That's why I want you to talk about this. A neighbor of mine who is a retired professor from UPM, he is an agriculture professor, and he was a very high functioning guy, and he likes to play golf. So I think 2 years ago, he went to one of the golf courses with his friends, about 4 or 5 of his good friends. And then while jumping across a ditch, he fell down, but he managed to get up. And GCS is 15 out of 15 because he can still talk and all that. And he told his friends that he just need a rest. So he go back to his hotel room. So while he's in a hotel room, his friend come to visit him intermittently, and found that he still can converse, and ask him whether he wants to go to hospital. And the patient and the professor say he doesn't want to go to hospital. And while he's in the room, he fell down again in the bathroom, and his friend helped him to go back to his bed. After 3 or 4 days, they found that he's not behaving appropriately, but he still can communicate. So they realized that something is wrong after 5 days. Well, his good friend realized that he is not well, and sent him to hospital, and found that he has an intracranial hemorrhage. So he was operated on, and after that he has a very poor recovery. I think he is still conscious, and he's not able to care for himself. And initially he was able to communicate partially with writing, but within 1 year he deteriorated very fast. And all the things that you just mentioned, the NG tube, the skin infection, and he eventually died from septicemia. He has all the tubes all over his body, but the family put in so much effort, and eventually he died. And it's a prevention, and the awareness of head injury. And these are not young people; these are old people who have some knowledge, and they are not aware that this head injury is so dangerous. So we summarize all the things that you just talked about.
You see, in this particular case, it's like a comedy of errors, isn't it? He fell, yes. Okay. Everybody recognized he fell. Obviously, the fall must have been significant because his friends went back to see him regularly. And obviously, they must have realized something was not right. Okay, at which point someone should have forced him to just go. He fell the second time. He should have put a gun in his head and said, go now. Okay. But what is very strange is that his deterioration is very slow, right? So to me, that doesn't sound like it doesn't sound like a significant head injury. There must have been a small contusion or something like that. And then this guy probably was dehydrating slowly, not drinking, developed other metabolic problems. Okay. I'm not sure whether surgery was actually indicated. I'm not sure from the sounds of it. Okay. This is my just listening to your story, because it's 5 days down the line already. So the blood clot is no longer life-threatening. Okay. There's a principle that if you take out a blood clot, you also take out some of the normal brain. Head injury patients, it's very simple now. The worst point of the patient is at the point of impact and when they come in. They will deteriorate for the first 24 hours or so, okay, because of edema. From that point onwards, they should actually be only improving. If from that point they are deteriorating, then other things are happening. Metabolic, seizures, some other things, hydrocephalus. So something about this whole case would make a very good case study to actually look at his serial scans and actually what happened. Because to be very frank, to me, it doesn't add up the picture. Something is not fitting in.
Okay. There's some of the background. He has diabetes, and so something happened. But according to the family, he's not on many medicine, and eventually he has hydrocephalus, he has seizure, he's on a lot of medicine. But the thing that killed him is the urine infection, and also the skin. He's developing blisters all over his body. So the family thought that it was a great suffering and decided not to proceed
Do
further.
anything. Yeah, so I think some of these problems that happened after that was not picked up properly and was not managed properly, right? Because the whole story doesn't fit. But it's pointless, he's already gone, so.
Yeah. Okay. Okay, with that, I thank your time and your sharing today, and I hope all of you can learn something and can apply to your practice. Okay, see you next time.
Okay, thank you very
Prof
much. Thanks
Vicky.
for having me. Bye-bye.
Thanks. Bye bye.